Good afternoon, everybody, and welcome to another Lunch and Learn. We are so excited to have Dr. Shane Speights back with us again. I'm Amanda McDaniel. I'm with the A-State Alumni Association. We're pleased you could join us today. And we're really glad that Shane is here with us again. He's the Dean of the New York Institute of Technology, the College of Osteopathic Medicine here at A-State. He's been in that position since 2017. He's originally from Arkadelphia, and he earned his undergrad degree at Henderson State, which is also part of our system now. And he did 2 years of pre-professional studies here at Arkansas State as well. He is also the Associate Program Director, he was before, and then Vice President of Medical Affairs for St. Bernard's Medical Center in Jonesboro. He's also currently the Medical Director for the City of Jonesboro, and he serves as the Craighead County Health Officer. He and his wife, Cheryl, who is a 1992 A-State graduate, they have 4 children and they live here in Jonesboro. So I'm going to turn it over to Dr. Speights right now so he can give us an update on all things COVID today.
Thank you, Amanda. And just a little bit too, so, and I'm always proud of my beloved wife. She was a Wilson Award winner here at A-State. She grew up on this campus because her father taught for many, many years and retired at ASU in the science department. He was in the sciences and taught microbiology, taught all the pre-med students, a lot of the physicians here in the area. Dr. Hink taught them. So she remembers fondly growing up on this campus and running around while her dad was working on campus. So long A-State ties.
Great.
Well, thank you so much for having me. I'll go ahead and get started because I do have quite a bit to cover. There's been a lot going on in COVID, certainly since the last time I spoke to this group, but just even in the last several weeks or so that we've been seeing. So I think it's important that once you leave this presentation, you have a general idea of everything that's going on COVID, not just here, but even around the country and maybe even a little bit globally. I'll try not to go that deep, but I'll go ahead and start sharing my screen so that we can get this started. All right, Amanda, do you see my slide there, the COVID?
Absolutely, update? Yes, it's right there.
And we'll go ahead and kick this off. So I think it's important, first of all, let's take a look at this map. This is a map of COVID infections, new cases in COVID around the country. And it's divided up based on counties. So each one of these little areas is counties. The dark crimson area is bad, just so you know. So those are high cases, areas of high spread of the dark crimson areas. The lighter areas, the light pale yellow, is minimal spread. Now, what I want to show you is this was 2 weeks ago. This is this week. This was this morning. I'm going to go back and forth. 2 weeks ago, this week. So kind of go back and forth and look now. You see, kind of pick a spot specifically as we're looking at Tennessee. We're looking at Kentucky. We're looking at West Virginia. We're looking at South Carolina. If you're having a question about what's going on down there in New Orleans, why is that light? Well, they had a hurricane. They're not getting a lot of good data in terms of infections down there. And so the testing has not gone well. But really, a lot of this started in the deep South, started in Florida, started in Louisiana, really started in our area in Mississippi, and is starting to move northward. And so this is the current picture of COVID in the U.S. today. Nebraska doesn't play well with others and doesn't like to report a lot of its data. That's why it shows not much going on in Nebraska. But this is kind of what you're seeing spread throughout the country, and we'll talk a little bit more about that. If we look at different states right now, I picked Idaho. Here's why I picked Idaho, because this is really the first time in our history of the pandemic that this has happened in the United States. They have implemented rationing of care. They are so overwhelmed with COVID in terms of hospitalizations, in terms of no beds to be able to manage these patients, in terms of limited resources. They, and what I read, quietly enacted, though it became national news yesterday, a crisis standards of care. What does that mean? It means they have to pick who gets a resource. So if it's a 65-year-old versus a 45-year-old that needs a ventilator, they have to pick who gets that ventilator because they don't have enough resources for everyone, or even a bed in the hospital in terms of where that patient goes. So this is rationing. This is rationing at its worst case scenario. This is the first time it's happened in the United States. Obviously, it's catching lots of national news. What happened when they implemented this is they actually provide immunity for healthcare workers in hospitals, so they can't be sued during this time for making those decisions on who basically lives or dies or gets a resource during this dire period they're in. You can see their hospitalization numbers in the top left-hand corner, higher than they've ever been since the pandemic. The bottom right-hand corner actually shows number of cases, and you see that they have spiked significantly. So this is a big deal. This is the first time, like I said, in the United States that we've actually seen this happen in one of our states. Moving on to Texas, I don't know how much you've seen about that. They've had a significant uptick as well. You can see their case rates are about where they were back in the January, February timeframe. And this is, I'm going to show you something a little bit about this graph as well. They hit a record high in pediatric hospitalizations, and some of their central hospitals in Texas have actually run out of ICU beds. Their school systems have been hit significantly. They've had to shut down 45 school districts in the state due to high COVID cases and significant spread, as well as quarantine. You can see that they had that actually affected over 40,000 students and is now taking them away from in-person learning, which is sad in and of itself. As with anything, whenever a crisis hits and when emotions run high, people start taking that out on other people. So it was disheartening to see there in the bottom right-hand corner that there's now lashing out verbal and physical attacks on healthcare workers that are occurring there in the Texas area. Looking at the graph there in the center, that pink graph specifically, what I want you to see, and I'll show this again on the Arkansas graph, but look over here where the cases, when we started seeing an increase in cases, this is 2020, and you see the September, October timeframe, and cases started going up. You see it was more of a gradual uptick right here up to the January peak versus what happened here. See how significant the rise was. See how much quicker they went to a peak here versus this gradual incline here. That is consistent with what you see with the Delta variant. We'll talk more about the Delta variant in a second, but that is consistent in what we've seen in other countries, and it's what we're seeing in states around the U.S., including our own. I'll show you that in just a second. Last state I wanted to cover before we move on to Arkansas is Tennessee. Obviously our next door neighbor, they are getting hammered with COVID as well. Remember, crimson is bad. You see the color in the bottom left-hand corner, that those crimson colors are not good. They're seeing significant widespread COVID cases. Actually, Tennessee leads the country in COVID cases right now. So they are the state with the highest number of COVID cases per day versus any other state in the country. When you break it down to region, the South has many more COVID cases than any other region in the country. And you can also see they're setting records for hospitalizations there in the top left-hand corner. Hospitalizations seem to have peaked momentarily, but even these peaks, when you look at them, they're at or they're higher than where they were previously, those records that were set back in 2020. I thought this was important in the bottom right-hand corner. Remember, on some of these statistics, states did not test or did not report testing during the Labor Day period. As you might imagine, if that's a 0, that significantly changes your 7-day average. And so sometimes you have to take that into consideration as we see these deep drops. Well, what happened there? Did they not have any spread? Well, no, there just wasn't any testing. There wasn't testing reported, and that's what happened there. Moving on now to our home state of Arkansas. Fortunately, we have seen kind of a peak and a plateau here in the state. We're still seeing significant spread. Again, remember, crimson is bad. That dark red is bad. You can see Northeast Arkansas is the darker areas of the state, as well as the Fort Smith area there in the central western side, north central western side of the state. Used to be central Arkansas. They've gotten somewhat better. They've lightened up a little bit. You can see we've also seen a peak in our number of deaths. I think that'll go back and forth, to be honest with you. I think that'll be more of a zigzag line. We had a high number of deaths that reported even just yesterday. If you'll know, vaccination rates were at about 43%. Just as a reminder, so Idaho has a low vaccination rate at about 40%. We're still low at 43% here in the state. Of Craighead County, Northeast Arkansas is even lower, and I'll talk about that data in just a second. Again, I'm going to draw your attention to, in terms of new cases, you'll see here the graph at the bottom. See how we had a gradual increase. So we gradually went up in terms of the October, November, December, January timeframe. This was the old COVID. This was the original strain of COVID. This is the Delta variant. See how rapidly you see this upshift. It's just because the Delta variant is so much more contagious and hits so many more people in a short amount of time. It can rapidly overwhelm your healthcare resources. And that's where Idaho is. And that's really even what we have seen here in our own region. We don't talk about it a lot. We've had some times where we have been short or out of those resources, even in our own region here. Luckily, hospitalizations have taken a little bit of the dip there. You see in the bottom right-hand corner. That's nice for our healthcare workers. They have just been slammed. They had a little bit of a reprieve there in the April, May time frame, but then cases picked back up with the Delta variant, and they have been busy ever since. Again, drilling down into the data here in the state of Arkansas. Really, the big things I want you to take home here is these numbers here in the central left-hand side of the page. This is still, this Delta variant, this current COVID surge is pretty much still a disease of the unvaccinated. And what I mean by that is it's not that individuals who are vaccinated don't get COVID, because they can and they do. But in terms of hospitalizations, in terms of those that end up in the ICU on a ventilator and those that die, the vast majority of those are unvaccinated individuals. And you see that's what the numbers show right there in terms of specifically that 90.7%, that's percent of hospitalizations in unvaccinated individuals. 88% are the percent of deaths in unvaccinated individuals. And that data is since February of this year. So it does include the Delta variant, which, like I said, we're seeing more of. Looking deeper into some of these statistics and the numbers, what I want to point your attention to here is in the center of the graph, the cases by age category. Back, I'd say a year ago, this 10 or younger, 11 to 17, they really weren't even a blip on the radar. There were some infections, we were seeing those, but not near the rate we are now. As a matter of fact, drawing your attention to this 18 to 24 range right here, 18 to 24, though we're seeing higher number of cases there versus 55 to 64. So this group here is starting to overtake, and this is consistent with national data. Information was just released this morning or yesterday that right now, pediatric cases account for 25% of all COVID cases across the country. So a quarter of all COVID cases across the country are pediatric cases. We do expect that number to continue to go up as schools continue to be in session and we continue to see spread. And again, this is largely due to the Delta variant, and I'll talk more about why in just a second. This is actually a closer look at the pediatric data, I believe. Yes, and the pediatric data in terms of cases. And this is the state of Arkansas. Looks at number of cases ever admitted to the ICU there at 102. Total cases ever hospitalized, 774. One of the things that I want to mention, part of the CDC when we pull this data, because sometimes you'll say, well, you know, what kind of shape are these kids in? You know, not to be callous, but are these kids that have you know, muscular dystrophy? Do they have cystic fibrosis? When you look closely at that data, 46% of the kids have no underlying health conditions. So it's almost 50-50. So about half the kids, a little more than half the kids, do have some underlying diagnosis or health condition, but about half don't. And so these are normal, healthy kids that are running around the playground. They get sick with COVID and end up hospitalized or in the intensive care unit. And so that's that. In terms of a pediatric infections, this is not an infection of just the pediatric ill or the pediatric patients that have some sort of underlying disease. We have normal, healthy kids getting sick with it as well. One of the things that's disheartening is that number in the bottom center there, that 13.1%. Remember, we have a vaccine, a safe and effective vaccine that is approved for 12 and older. Yet we only have 13% of our population in that group that is actually vaccinated. Yeah. When we drill down closer to Craighead County, and these are Craighead County numbers, so these are numbers that are more specific, obviously, to our region. That graph in the top left, Yes, you're reading it correctly. Our numbers are higher than they've ever been in Craighead County. And that's why we're crimson on that state map in terms of number of cases in the area. So here in Craighead County, we are seeing more COVID cases than we have since the beginning of the pandemic. We saw a little bit of a drop recently. We're still averaging probably 110 cases per day. Again, some of the reporting has lagged because of the Labor Day weekend, but right now that's still where we feel like we are. Same graph again, dynamics that you've seen on the other graphs. It was a slow increase here for Craighead County over a period of 4 to 5 to 6 months, as opposed to this rapid increase, which is where we are now. Rapid increase and a plateau. Similar to what we've seen in Arkansas is that rapid uptick. It kind of peaks up and comes down, but we're sustaining this higher rate. In the state of Arkansas, and I didn't mention this when I was on that graph, back in the early spring, back in this time period here, where we were really seeing low spread, we were averaging maybe 180, maybe 200 cases per day here. Now in the state, we average about 2,000 cases per day, between 2,000 and 2,100 cases per day. And that's kind of where our plateau is right now. So we're kind of sustaining that number. In the top right-hand corner, these are our resources, specifically our hospital resources in Craighead County. Now that narrows it down. We've only got 2 hospitals in Craighead County. So this is the hospital data for St. Bernard's and NEA Baptist in terms of percent ICU beds used, percent beds used overall, and new admissions. You can see that we hit a peak about 7 to 10 days ago and have seen a decline. That's consistent with the other data that we were seeing, but they were seeing numbers really higher than they had seen previously. When you look back at the October 2020 period or even the January 2020 period, our healthcare workers have been working overtime, to say the least. The other thing that I want to draw your attention to on this slide in particular are these numbers right here. Here in Craighead County, our fully vaccinated rate is only 34%. And so that's much lower actually than what the state vaccination rate is. So we struggle here in Craighead County and really several counties here in the Northeast in terms of vaccination rate. The other concerning number is that bottom number. This is the percent of the population over the age of 65 that is fully vaccinated. That's only 60%. Okay, this is still a disease that really hits the elderly and the older individuals hard, specifically those that are 65 and older. In most areas, the 65 and older rate has a much higher vaccination rate. They're approaching 75, 80%. And so this is concerning because we still have a lot of individuals who are not fully vaccinated in our county and in our community that are at high risk of a bad outcome if they get the Delta variant in particular. So that's something that we need to certainly spread the word and do a better job on, is making sure that our individuals 65 and older are fully vaccinated. Moving on to the Delta variant itself and talking about some of its genetic lineage, this is actually a graph that the CDC puts out where we follow the more predominant strain in the area. You can see we started back in June. The predominant strain was actually still the Alpha strain. That was still the strain that actually had come over, the UK variant that we were watching. That was still something that was coming around. And then rapidly the Delta variant. The Delta variant is that B1617.2. That's that kind of orange there bar that just takes over. And now 98% plus of the cases in the US, including here in Arkansas, are the Delta strain, the Delta variant. And so I'm going to talk more details about that. You've probably heard about different types of variants. I'll talk about a couple of different types of variants in just a second. You may have heard about the Mu variant, but remember, that's a very, very small percentage. Are there cases of the Mu variant here in Arkansas? There are probably a couple of cases here. They talk about cases throughout the US, but it is not a significant player right now in terms of the variants. The Delta variant is the biggest player. That's the one that largely people are getting infected with, that we're seeing hospitalizations from. We do follow these other ones, but it can create anxiety if you try to follow every variant that's out there. I assure you, we followed this on, there's some great open source websites that follow these variants. And there are literally, there are just, dozens and dozens and dozens of different types of variants out there that are followed, the majority of them kind of burn out or kind of, they get overtaken by another strain of the virus in terms of being spread. You don't see it change. Like the Lambda variant's a good example of that. We just haven't seen that really taken off much. And so the Mu variant is something we'll be watching. I know it's been on the news recently, and I'll talk more about it in a second. Actually, I'll talk more about it right now. This is the Mu variant. In terms of your concern on the Mu variant, really only if you're in Alaska is it a big concern, or you're traveling to Alaska or have someone from Alaska that is visiting you. That's where the largest number of cases are. Is it found in other states? Well, yes, there's a few cases here and there, and you can see on the right-hand corner the number of individuals that where the virus has been identified and it has been sequenced. And what you see there in the bottom left, and not to get too technical, although this is a handful, this is actually the genetic sequencing and where the mutations occur. The mutations are important because that tells us or gives us an idea about how contagious it is. Will it be able to evade our vaccines? Will it be able to evade our immunity if I got COVID before? Does it start over like a new virus? Watching all the mutations and where those mutations occur kind of help us try to decipher that. Doesn't always translate into what happens real world, but it's the best we can do, and it gives us the best idea right now. The AY4 variant is really something that we're seeing more in the state of Arkansas, and that's why you see Arkansas, certainly in Vermont, being in the darker colors. This is a subclassification of the Delta variant. So this is almost like a son or a daughter to the Delta variant. And we've seen this. I've actually seen this in our clinic here on campus. We've actually genetically sequenced this variant and so have identified it. It's still too soon to tell exactly what this variant does. It does seem to make the individual a little sicker a little longer, but it's still too soon to, you only have a few cases of it, so it's hard to know, is this true for everybody? So still following this right now. We do believe that between the typical Delta variant and this AY4, as well as an AY3.1, that's what we're seeing here in our community in Northeast Arkansas, are those three right there, with the Delta variant being by far the most common. There are still a few cases of what we'd call the Alpha variant or the UK variant. But again, 98% of the time, what you're going to see here is the Delta variant. And that's kind of what's been played out. Now, so moving on to the Delta variant itself and exactly what is the Delta variant, and, what do I need to know about it? Just as a reminder, so right now it's spread widely throughout the globe. Actually, most countries are now experiencing the Delta variant, discovered in India back in December of 2020. Remember where variants come from. Variants come from rapid, overwhelming spread of a disease in a certain area. So specifically in this context, you had a lot of people get sick by a virus. And so once the virus jumps from person to person, it has a chance to change genetically. And once it changes genetically, then it can jump to somebody else, and there can be a change there as well. And so when you have really hundreds of thousands or millions of people get infected by a strain, you're going to have variants crop up. And that's what happened. Globally, there was a whole lot of virus spread between November, December, and January of last year. And that's what happened. This Indian variant cropped up, hit the US in March, and now the predominant strain. Look at those numbers, though. It was only about 1.3% of cases in May, and then it jumped to 9% in June. 82%. So from June to July, it jumped from 9% to 82% of our cases. And now we're at 99.1% here in September. Lots of mutations on the area we call the spike protein, which is how the virus actually invades your body and causes infection. The big thing about it, there's so much more virus with the Delta variant. Someone that's sick with the Delta variant has about 1,000 times more virus in their nose and mouth than it versus if they were infected with the original strain. Because you have so much virus there, number one, it hits your body 1,000 times harder. You're also spreading it 1,000 times more. What about the symptoms you have? Oddly enough, we're not seeing too much in terms of, there's some that have cough, and we're not seeing a lot with loss of smell or taste. So because of this variant, you're seeing a little bit of difference in terms of the symptoms. Most people are presenting with sore throat, headache, runny nose. They may or may not have fever. Some of it depends on whether you're vaccinated or not. Those that are fully vaccinated may have, or we would expect to have, milder symptoms. And so they may kind of just blow it off and say, this is just Arkansas field burning. I just got a little runny nose, or I always get allergies this time of year, whatever it may be, and just kind of chalk it up to that. We are seeing that, and then all of a sudden they get sicker over the progressive 2 to 3 days. And so it's important for people to get tested, even if they feel like they have mild symptoms. This is, again, a more contagious strain than the original one. Remember, or I've got there listed, with the original COVID strain, if one person was infected, they would typically infect 2, maybe 3 other people. That's on average what we would see. With the Delta variant, with one infected person, they're going to infect anywhere from 5 to 8, depending on what numbers we look at. It says 5 to 7 or so. So you're going to infect a lot more people. That kind of goes back to the graph I showed you earlier in terms of the steep increase that occurs in terms of cases. That's kind of played out. So that correlates with what we're seeing here. What about its severity? Is it a more severe virus? Well, right now we think it may be. And we've got a couple of studies we've looked at, one out of Scotland, and there was 2 more, one out of Singapore and Canada. And it looks like the risk of hospitalization from Delta is much higher, even double in some cases, though we are seeing good response from the vaccines. So hospitalization and death do seem to be higher with the Delta variant. That's also what we're seeing here locally as well as across the country. Well, can you test for it? How do I know I have the Delta variant? Well, yes and no, we can test for it. You need to know this. If you're here in Arkansas or even Craighead County, Jonesboro, or wherever you are, and you test positive for COVID, 98% chance it's the Delta variant. And so that we don't really send it off for genetic testing after that. If you're sick for a longer period of time, like let's say you're 6 weeks in or 4 weeks in, and you're still sick with this, we may send you off for genetic testing, or if there's some sort of abnormality in terms of your presentation, we might send it off for genetic testing, but we don't routinely send off all of these tests for genetic testing. Once you test positive for COVID, right now, because of the likelihood that it is the Delta variant, we just leave it at that. There are some third-party labs that do sequencing just to make sure we try to catch some of these variants, though that's not really at the level it needs to be either. Well, what about being fully vaccinated? I got fully vaccinated. Now, why in the world do I have to wear a mask? I thought that's why I got fully vaccinated. I mean, isn't that why I jumped through all these hoops to begin with? And you know what? Back in the day when it was the original COVID strain, the answer was yes. When we were talking about just the regular COVID strain, and this will become a bigger conversation in just a second, the answer was yes. If we were just talking about the run of the mill, then you didn't have to wear a mask. You could feel comfortable going out in public, hanging out with friends. Really, and then the CDC even had this on their website. You can go about doing what you did before the pandemic. Well, that's awful liberating, considering the fact that we were, under this thing for the last year. So what changed? Well, the virus changed. And when the virus changed, it changed the rules. And so we know now that with the Delta variant, even individuals that are fully vaccinated can get it. Not only can they get it, they can spread it. And this is a study that actually shows how much they can spread it. The green dots represent individuals who are fully vaccinated, but got the Delta variant, got infected with the Delta variant. The red dots are unvaccinated people. I want to draw your attention to the left side of the graph over here, where what you'll see is there's the curve that kind of goes up. So basically up in this area here, within the first probably 4 days of infection, the vaccinated and unvaccinated individuals can spread the virus about the same amount. And you may have heard about this in the news. And so this is the graph that actually where a lot of that data came from. And so this is what you're seeing here is where individuals in either group can actually spread the virus. Now, once they hit this about day 4 or so, between day 4 and day 5, the vaccinated individuals drop off dramatically. So their risk of spreading it is much lower. However, those that are unvaccinated, look at this group over here in the center. You're talking about 15, 18, 22 days out, they are still able to spread the virus in some cases. And so that's where quarantine comes in for individuals that have been exposed, obviously isolation. It's also where the information or the guidance from the CDC came out that said if you were exposed and you're fully vaccinated, you should get tested in 3 to 5 days. That this is where the 3 to 5 day window comes from, is to be able to, number one, allow the virus to replicate so we can pick it up on the test, but also be able to pick, but you should be wearing a mask and limiting activities and being tested at 3 to 5 days. So this is why universal masking for everyone, regardless of vaccination status, is recommended, is because really the game changed. The virus changed. If we were dealing with the old one, then we wouldn't have to do this, but we're not dealing with the old one. We're dealing with the Delta variant. Well, what about the vaccines? When we talk about the vaccines, how effective are they against the Delta variant? They're very effective. But one thing that people seem to have forgotten is when we talk about the vaccine itself, what's the primary purpose of the vaccine? It's really not that I don't get the infection at all. That's what happened early on when we talked about the original strain of COVID. The vaccines were phenomenal in terms of even just preventing you from getting sick. But the big thing about the vaccine is I don't want significant morbidity or mortality. Morbidity means I don't want something long lasting, and I don't want to be in the hospital. I don't want to be in the ICU. I don't want to be on a ventilator, and I don't want to have recovery period of 6 months trying to get over this. And I don't want to die from it, oh, by the way. And so that's the big thing that the vaccines do protect from. So the current COVID vaccines do an excellent job reducing or preventing morbidity and mortality, which means that if you're fully vaccinated and you get infected with COVID, you may still have a runny nose. You may still have a little fever. You may not feel good for a day or so, but the likelihood of you being hospitalized in the ICU, on a ventilator, or dying is extremely low. And every study that we're seeing now actually shows that. One of the recent studies from the Mayo Clinic looked at almost 120,000 individuals with Pfizer versus 60,000 with Moderna. The Moderna vaccine actually performed a little better in this group here, but even the Pfizer vaccine, still, again, individuals were protected 85% from hospitalization, 87% in ICU. There weren't any deaths in either vaccine group. You did see Moderna outperform Pfizer again on hospitalizations, ICU admission. And when we talk about any infection, remember, that's the runny nose, that's the I don't feel good for a day. Yes, it was much lower in Pfizer, but I'd rather take the I don't feel good as opposed to being hospitalized. One of the other things to remember is, and I don't know if you guys recognize this, we were seeing some of it and hearing about it in our clinics as well. Individuals that had the Moderna vaccine, they seem to have a pretty stronger reaction than the Pfizer vaccine. They may have felt a little worse a little longer, or it may have been that it really kind of hit them. The reason why, and it shouldn't be surprising, because the Moderna vaccine actually had 3 times the mRNA per dose in their vaccine versus the Pfizer vaccine. So there was more vaccine, basically, more mRNA vaccine in the Moderna vaccine versus the Pfizer vaccine. So we expect that that's why individuals that had the Moderna vaccine felt more of a response to that vaccine. It's also why in this study here, Moderna fared better in terms of any infection, hospitalizations, and ICU admission. I get a question frequently about this. If I've got COVID and I get COVID now, when can I get my vaccine? The CDC says that you need to wait a minimum of 10 days. They want to make sure you clear the virus before you add another insult, so to speak, by getting that vaccine. So you want to make sure that you're over and have cleared the current infection. The vast majority of people get over the vaccine or get over a COVID infection by about day 10. If you were hospitalized, you have to wait longer. If you were in the ICU, you have to wait longer. That's a discussion to have with your physician. But most people that have a mild disease from a COVID infection, you need to wait 10 days before you get your vaccine. What else is going on with vaccines? I get a lot of questions about booster vaccines. Right now, the way it currently stands, the FDA has allowed for the 3rd dose in specific immunocompromised individuals. And what I mean by that is solid organ transplant recipients. There's actually a slide, I think I took it out, I apologize, it's not on here. The CDC actually gives about 5 to 7 different scenarios where an individual right now can qualify for a third booster dose. And it's right now, it's only for Pfizer and Moderna. Johnson & Johnson doesn't have that approval yet. Well, what about booster doses for the rest of us? So, and this has not been the perfect pandemic for sure. I don't know that there ever is one. The White House came out and said, hey, we're going to have booster vaccines for all by September 20th. They got ahead of the CDC and certainly got ahead of the FDA as well, because we have to go through and look through that data and make sure that it's something that's needed, something that's safe to do. We have some preliminary data out of Israel. They started doing third dose boosters the middle of July. And the data looks really good there, but I think the White House got out ahead of the CDC and FDA, and that's not a good thing. We do expect that there will be a rollout, and it may be similar from what I'm hearing to the rollout they had for the original vaccines, where individuals on the front lines can get it, as well as healthcare workers, fire, EMS, police, and that scenario there. So in addition to individuals based on age, I would expect they'll roll it out to nursing home individuals. The data does look good on booster doses from what we can see from Israel. Remember, we don't really have that data here in the US because we've not done it. So we're looking at some foreign data, but that Israeli data is actually really good. In terms of FDA approval, most of you probably are already aware that the Pfizer vaccine is FDA approved. It's the only FDA approved vaccine that we have right now. What does that really mean? Well, really to simplify it, what happens is to get the EUA, the Emergency Use Authorization, what has to happen is once the company completes their trials, they have to wait 2 months, and they have to go back and then look at the study participants and make sure there was no bad outcome, or make sure that the drug or the vaccine did its job. And so that's what happened. They did that, and that's how they got EUA, and that's how Moderna got EUA. To get full FDA approval, you have to have 6 months worth of data. So not just 2 months, you got to wait 4 more months, and you got to collect all that data, and you got to go back and look at the study participants. So there's nothing that was changed in terms of, oh, now they looked at a deeper dive of the safety, status of it. Nothing like that happened. It was just that they looked at more data, because it has to be a safe and effective drug or vaccine to even get the EUA, or they wouldn't allow the EUA. The move from EUA to FDA approval occurs just based on looking at a longer amount of data. And that's what happened. Moderna has submitted their data in June, but we've not heard on when they might get FDA approval. Hopefully it's before the end of this year. Johnson & Johnson has not applied for FDA approval. They don't have all their data together. They'll probably apply later this year or the first of 2022. What about kids? A lot of people are asking about that. The kids under the age of 12 right now, we do have Pfizer's approved down to age 12. What about kids under 12? Pfizer is the only company right now, all three companies are working on it. Pfizer is the front runner. They're expected to release their data by the end of September. And they expect to go for FDA, EUA approval the 1st of October. Why does it seem like it's taking longer? Because it's a different dose. It's not the same thing that individuals that are 16 or 26 or 35 or 65, we all kind of got the same dose. This had to be a different dose, a different formula, and you had to get enough data together to prove safety and efficacy. I'm really looking forward to seeing that data. We expect it to come out at the end of this month. And if it looks good, we expect that they'll go for FDA EUA by the 1st of October. How long will it take them to actually roll out the vaccine? That hasn't been discussed in terms of what that looks like for vaccine rollout, because it will be a different formulation than the previous one that we've been getting. I get asked about contraindications to the vaccine. There's really not a disease or specific diagnosis that means that you're contraindicated. Obviously, a contraindication would be an allergy, severe allergy to any of the vaccine components. And if you had a severe allergic reaction within 4 hours of getting your first dose, the CDC says you should not get the second dose. So those are kind of the things. And by the way, for individuals who get sick with COVID, if you receive monoclonal antibody treatments, you have to wait 90 days to get your vaccine. So those are kind of some of the main points there in terms of individuals who can't get it. I've had people ask, I put that little blurb there in the center, what are really my chances now that I'm fully vaccinated of getting COVID and the Delta variant specifically? This actually was posted by the New York Times, and it says, on average, it's a 0.02 to 0.01% chance of getting COVID, or a 1 in 5,000, 1 in 10,000 chance. That does depend upon how much virus is being spread in your community. So I don't know for sure that translates into what we're seeing here in Craighead County, because we obviously have a lot of virus being spread around in our community right now. This study came up. I added this because this is a question that's come up just recently. The Israeli study on vaccinated versus naturally infected individuals. The study showed that individuals that had COVID previously, they had higher antibodies than individuals that got fully vaccinated. And they looked at 3 different groups, and these groups were individuals that were vaccinated or had infection prior to February of 2020, or February 28th of 2021. So this is before the Delta variant. They showed that individuals that were previously infected with COVID had better immunity than those that were fully vaccinated. Those previously infected with COVID and having 1 dose of mRNA vaccine had the highest level of immunity. Those fully vaccinated without prior infection had the lowest level of immunity. Now, when this came out, I think it got caught on social media. They're like, hey, if I got sick with COVID, I'm better off than if I got the vaccine. For this subgroup, that is true. And it should be no surprise to you that if you get the infection, your body mounts a pretty good response. And this is not new in vaccines in general, in terms of if you get sick with the infection, you're going to generate a bigger response if you make it through the infection than actually the vaccinated antibodies that are created. But here's the big deal. They looked at individuals before Delta. So these are individuals that had gotten infected with the original strain of COVID. This is also individuals that got fully vaccinated based on the original COVID vaccines. Remember where the original COVID vaccines, what they were formulated for. They were formulated for the original strain of COVID. Hence the conversation about booster vaccines, because this study did not talk about booster vaccines. But this is not, none of this is surprising. I think it was kind of taken out of context. That's not surprising either. But what it is the individuals that had COVID previously, yes, they should have a better antibody response versus the individuals who had COVID or had the COVID vaccine based on the original formula. That's why we've added the booster vaccine now that we're in a different conversation with the Delta variant. And so that's why the booster vaccine is going to be so important moving forward in terms of that additional layer of protection for individuals that are fully vaccinated. Now, the other piece that's not, that was skipped over as well is an individual who had COVID previously and got 1 dose of an mRNA vaccine, which is Pfizer and Moderna. They were the best protected, because they not only had the antibodies from the infection, they had the additional antibodies from the vaccine itself. And so those individuals actually, and this was a good study, that the group that they look at, there's like 2.9 million people in these cohorts they're looking at. So it's a large study. It's still, by the way, hadn't been peer reviewed. And so it's preliminary data. And we have to be careful about that as well. Thought I'd go through just to break down some cases here in the US, specifically by age. And I'm gonna zoom in a little closer. Look who's getting sicker, or look who's getting cases of COVID in the US now. And what I mean by that is you can see that 16 to 17-year-olds are leading the pack, followed by 12 to 15-year-olds. And then you've got your really 18 to 39 is what that group is there below it. And then 5 to 11. So you can see how we're seeing a surge in cases in not only school-age children, but in college-age kids as well. This is national data. This is across the U.S. You see from May to August the 28th. And so don't be surprised. And largely this younger generation is not vaccinated or can't get vaccinated. So we're seeing significant spread of COVID cases in this group. And this comes straight from the CDC. I want to wrap up. I've got, this is with some myth busting, we'll say. And I'm going to try to hit this fairly quickly for you guys. I know that we're, I think we're about 15 minutes or so from wrapping up. So should be plenty of time to wrap up and be able to answer any questions you may have. I just want to hit a couple of things on this. Some of you may have heard about this Indiana doctor. Well, I say doctor. He is a physician. Oddly enough, he's an ophthalmologist. He didn't have any training in family medicine. He called himself a family medicine, but he's not board certified in family medicine. Did an internship and did a 1-year program in internal medicine and then a residency in ophthalmology. But I think what happened was he got a lot of publicity when he spoke in front of a school board. He got about 90 million engagements, actually. And at the end, he was trying to basically sell his combination of vitamins and supplements to ward off COVID. None of this information was credible that he spewed out. Unfortunately, I think he just took his fancy medical terminology and spoke over everyone's heads, which is unfortunate in an attempt to really help his pocketbook. You may have heard of America's Frontline Doctors. This is one of the individuals who had the gynecologic theories about aliens and really for women that have menstrual irregularities, it's because an alien has infected you. There's also an individual that Dr. Simone Gold, who has her picture in front of Cedars-Sinai. She never worked there, but she tried to pass herself off of working there. They passed off hydroxychloroquine. Basically, COVID is really not as dangerous as it seems. Vaccines don't work. There's more people dying from vaccines than COVID, which is not true, and that big pharma is behind it all. I will say this, it's going to be no surprise. Pharmaceutical companies are making money off of the vaccine. They sold them to the US government. Pharmaceutical companies make money off of every drug, whether it's a drug that you're taking for your cholesterol or your high blood pressure or what have you. I don't want to get too much into a big pharma discussion. I think there's certainly some reform that could go on there for sure. The frontline critical care physicians, these are the individuals that were pushing largely the ivermectin. I think you can go online there and get a teledoc visit for about $100, and they'll write you a prescription for that, in addition to some other medications. One of the things about the frontline physicians, I feel bad because what happens is that, well, actually, I'll take it back. I'm gonna get to that in just a second. Hold that thought on that. They did a study recently. It was the New York Times, I believe, the 12 top individuals responsible for the majority of disinformation on social media. They called them the Disinformation Dozen. Unfortunately, that individual on the left was number one. They produced over 65% of the misinformation regarding COVID vaccines. And the nanoparticle guy, I'm actually going to talk about him in just a second as well. Talk about masking has been a big debate across school districts as well. Let me just cut to the chase. The data is clear that masking in schools does reduce the incidence of COVID infections, and it reduces the spread not only from staff and from faculty to students, but vice versa, which means you don't take it home, which means the student doesn't take it home to their parents or grandparents. Every major organization in the country, as well as the state of Arkansas, supports the CDC recommendation regarding universal masking. You saw the graph earlier in terms of even individuals that are fully vaccinated need to mask, and why. And the other piece to remember is that kids under the age of 12 can't get the vaccine. So there's no protection for them other than the mask. Now, the mask is a part of a larger strategy. You don't just mask, you have to do hand washing, fogging of the rooms, ventilation systems need to be maintained, but it is key, and it is part of a full strategy. The CDC did a really good job going through. These are some of the articles they quote. These are the studies that have actually shown that masking in school districts work. How did we get this data? Well, we got it from last year, because this happened last year and we saw it. We saw counties and school districts that implemented masking, and we were able to then track that and look at their COVID rates. And so that's how the CDC was able to come up with their guidance for this school year, is they looked at the data that occurred last year all across the country and across the world in terms of schools that had mask mandates. There has been follow-up data on this as well that just continues to show that masking is safe and effective. And for those of us that want to keep our kids in school, want to keep the kids face-to-face and keep learning in person, masking has to be part of the overall strategy. This guy, I don't know if you've heard about the nanoparticles in terms of female fertility, infertility. The vaccine, actually, these nanoparticles supposedly congregate in the ovary and can influence infertility. So he's a millionaire entrepreneur. He's a CEO of a digital marketing firm, has no medical background, no science background, no research background at all. He pulled a study that Pfizer had pulled out, a rat study that Pfizer had pulled out, and he misinterpreted it. And this is where really an example of where a little data or a little information can go very, very wrong. And so then he put this out on his social media. He missed the fact that, number one, it was a rat study, but number two, that the dose given to the rats was 18 to 35 times higher than that used in humans. And so it wasn't even close to what a human would receive in terms of the vaccine. He actually misinterpreted what we call the absolute relative risk versus the, absolute risk reduction versus the relative risk reduction. It's an epidemiological term. He's not an epidemiologist and didn't, I guess, have access to one to explain it to him. Brought a guy on his show who also misinterpreted. This is a vet at a school in Canada who misinterpreted 2 vaccine studies. And actually the studies showed no harm at all that he quoted. The problem is this information gets shared widely. It gets shared widely and broadly. And so you have 14,000 Facebook interactions based on this, at 5,000 shares, 1,800 interactions on Reddit. But the real story that came out that actually went through and explained where he had misinterpreted only got 1,300 shares. I've got the copy of it right there if you're interested in that. The latest thing that we're seeing now is on ivermectin. FDA approved ivermectin. It is FDA approved. It's FDA approved for the treatment of parasitic worms. And it's a great drug used in third world countries to prevent river blindness, to prevent some horrible infections in third world countries. What it does is it actually blocks chloride channels in terms of the nerve cells and the muscle cells of worms and actually paralyzes them and kills them. Viruses don't have nerve cells and viruses don't have muscle cells, and it just doesn't work that way because that's not the way it was created. That's not what it was intended to do. And in terms of the dosing, we typically dose it once. Like you take 1 dose of this and you're good, or you might take a dose every other day for a maximum of 15 days. And so the dosing, the individuals that are taking this several times a day for weeks on end as either a treatment or preventative, that's why we're seeing cases go up in poison control and admissions to the hospital for really damaging effects, liver and colon damaging effects to this medication. This is another example of taking something out of context. It came from an Australian researcher in 2020 who used very high doses, basically in a petri dish of this medication. And so people took that and extrapolated and said it must work for humans. And we've just not shown that it has. The latest research that we have seen shows no benefit to it. And that came out, I guess, about 2 months ago. And so the data is just not good either way, which is why the FDA, the CDC, and again, all major organizations say this is not something to be taken. There was a great overview of this by a physician, a Dr. Perry, in the bottom right-hand corner. You can look, it's on Medscape, Dr. William Perry. He did a great job. He's a Harvard graduate. He now teaches at Yale. He's an MD, MPH, as MPH and studied epidemiology. He does a great job going through the actual studies of this and kind of explaining it. Why is it that the FLCC group, picked this up? That was that frontline physicians. Well, what happens sometimes, and this happens, by the way, well, let me just say this. So I've worked in the hospital, worked in the ICU, worked in the clinic, for years. It is not uncommon for physicians, nurses, respiratory therapists, whoever, we do everything that we can within the standard of care to save someone's life. So this is not uncommon in the ICU. You get to the point where we're doing everything we can and nothing's working. And so we may take a step back and say, well, maybe we should try this. And it's not that we're throwing anything at them, but we try to figure out some mechanism. Well, what about this? And we joke and call it, we call it the IV kitchen sink, which means we've tried everything else that we know will work for this disease or this condition. What about this? Now, there's no evidence to support that. And that's not a way we do studies. It's not a way we do research. We do research in controlled situations, because what I may see at the bedside is not really true or what translates when you try to apply it globally to people all over the state, all over the country, all over the world. And just because I may do something and hey, 2 or 3 people did okay with this, That does not mean that the medication made that much of a difference, because you have to take out, we have to what we call blind those individuals, which means you have to, number one, you have to control it. So it needs to be, you took the same type of patient, they all had the same kind of comorbidities. You could imagine if I had a study where I decided I wanted to give a drug to individuals to see if it worked, if I cherry picked and only gave the drug to 25 and 30-year-olds versus I didn't give the drug to 75 and 80-year-olds, well, those individuals are going to be at a higher risk of dying anyway. So then I've just biased the study. And so that's why we do research studies, is to remove all that bias. So I think that's where some of this has come from, which is unfortunate. This one I hesitate to even go too much detail in. This actually is something that's being circulated that says that COVID doesn't even exist. Again, I hesitate to even go too deep into this. This is just a misinterpretation from something from DHS when there was a question about COVID being real and being able to be isolated. COVID has been isolated hundreds of times in labs all over the world. That's actually how we're sequencing it now, and that's how we know that it's having genetic changes. This is a more common one about influenza. This is information that's freely available. You can go to the CDC website. You don't have to have some super secret password to get this. You can actually go to the CDC website and pull this up. On the right-hand side, you can see how many people died each year from influenza. On average, about 35,000 people per year die from influenza. To date, 648 to 650,000 people have died from COVID. That means that if we take the number of people that have died from influenza, again, about 35,000, and we tried to figure out, well, how many people would need to die, it would be 18 years worth of death from flu to even get close to the number of people that have died from COVID over the last 18 months. I don't know why this gets recycled, because the data is clearly out there, and we've tracked this for years and years and years. There's one thing that we do really well in the US, and it's track deaths. And so we've had this for a long time, so this is not new information. COVID is by far a harder disease, a more deadly disease, a more infectious disease than influenza. You should also remember, though, as while we're on this topic, please get your flu shot. Is it possible for you to get flu and COVID at the same time? It absolutely is. So this is not the year to not get your flu shot. Some quick hits here. Zithromax, the latest data is not good on it. Zithromax is no better in terms of treatment of COVID. Vitamin D. Vitamin D is vital to your immune system, but you only need to take it if you're low on it. Who's low on vitamin D? Older individuals could be lower. People that live in the northern part of the country are low. People, if you're from Boston or live in Boston, you're probably low on vitamin D. Individuals that live in the south or closer to the equator, we're probably good. How do you know? You check a vitamin D level. But just taking more vitamin D is almost like trying to add more gas to a full gas tank. It's just going to spill that onto the ground, and you're just, it's not going to do you any good. It's not like extra vitamin D really helps you. Looked at reflux medicine, no benefit to that. Hydroxychloroquine, we've had multiple studies on that, and really no benefit there. Fenofibrate, there's a theoretical benefit there, again, based on computer models, but the data hasn't panned out there. Even remdesivir, which is actually a medicine that was approved for the treatment of COVID. It's an antiviral medication. The recent data has shown no mortality benefit. The best treatment we have right now for COVID is monoclonal antibodies. That's the treatment that has continued to show consistent positive results on treatment is monoclonal antibodies. Luckily, it's available at all of our hospitals here in this region. I get this asked a lot. There's so much misinformation out there. Who do you listen to? Well, this is who I listen to be honest with you. And it's multiple sources. I listen to national groups because this is what they did before COVID. This is what they will do after COVID. They'll put out good, consistent data to the best of their ability. And so this is who I follow in terms of journal articles. Eric Topol is on Twitter. He does a great job. Perry Wilson, that was the individual I was talking about earlier. National societies, respected medical schools and universities. Luckily, I have excellent colleagues. Dr. Abraham is an infectious disease specialist. He's boarded in infectious disease. Dr. Casey Holder, local chief medical officer at St. Bernard's, graduated top in her class in medical school. Dr. Rosnarian, he has actually studied the SARS virus. He has been at the University of Buffalo, the University of Tulane, the University of Jackson, Mississippi. We have him on staff here. He is our Dean of Research at NYIT. Another resource, Dr. Tony Slayman, teaches immunology, virology, and microbiology here at the medical school to all the next generation of physicians. So these are individuals that I call on in terms of, hey, am I seeing what I think I'm seeing? Where we go from here, what's it going to look like? This is India. This is India. This was the Indian. This was where the Delta variant came from. You see how it went straight up and went straight down. The reason why it went straight down is because they went into countrywide lockdown. That's not going to happen here. So they went up within 7 weeks, they peaked, and they went straight down. In the United Kingdom, which is more similar to us, they went up in 6 weeks, started down, and have now gone back up and started to plateau. So they're at a little higher. This is probably what's going to happen to us here in Arkansas, here in the United States. Here in Arkansas right now, again, we followed exactly what happened in the UK and really what happened over there in India. We peaked in about 7 weeks, and now we're starting down. What do I think is going to happen? Well, we could turn and do this. We could turn because we're about to enter into the cold season where everybody spends time inside. Schools are in session. People are going to gather for holidays. This would not surprise me at all. I would love if we do this, but I'm not sure we're going to do that. What do I think is really going to happen? It's probably going to be something weird like this, where it's just an up and down throughout the fall and the winter time frame. I do think we'll be on the backside of this in the spring, but there's a big question mark over the next 4 months and how COVID, specifically the Delta variant, is going to affect our holidays coming up as we move into this colder weather. And with that, I will go ahead and stop, and I'm happy to answer any questions you guys may have.
Thank you so much, Dr. Speights. That was very informational. And you covered a lot of the questions that we had submitted, but there was some specific questions. What is the difference between getting a third vaccination versus a booster shot?
So there's really not a difference. Let me back up. It's the same dose. It's the same formula. It's just more the timing. And what happens is when you get that, first dose, your body gets primed. It gets in there, you create antibodies. When you get that second dose, then it really kind of starts ramping up. You get more antibodies. The idea behind the third dose is that even higher antibody load. And the more antibodies you get, the better your chances are of warding off one of the variants. Remember, the vaccine itself was actually formulated based on the original strain of COVID. But when they formulated it, they covered the entire spike protein. So all these mutations that occur on the spike protein. So the booster dose will help you in terms of being covered from a variant like the Delta variant, and really any of the foreseeable variants now. As a matter of fact, the first 2 doses, they were very effective against like the Alpha variant. We're looking at Beta. We're looking at like the South African variant. We had good protection even with just the first 2 doses. It's the Delta variant, which seems to have more mutations that people are worried about, that we think that third dose is needed.
Okay. And what if you got the Moderna vaccination, you got your 2 doses of that? Can you get the Pfizer as a booster, or do you need to stick with the same vaccination you started with?
Right now, the recommendation is that you stick with the same manufacturer that you started with. However, there is if that's not, there's a whole, if that's not available, you can do the other one. What you can't do right now is mix match Johnson & Johnson in there. So if you had Moderna and Pfizer's the only thing available, then you can take Pfizer, or vice versa. If I had Pfizer and the only thing available is Moderna, I could take Moderna. But you can't take Johnson & Johnson. If you had Moderna, you can't add Johnson & Johnson. So it has to be, and it's because of the vaccine technology. Pfizer and Moderna are of the same technology and the same platform. Johnson & Johnson is different. It was a different vaccine technology, a different platform. And so that's why you can't do that. But they prefer, if at all possible, that you stick with the same manufacturer.
Okay. And we had somebody ask also, they were one of the individuals that had a severe allergic reaction to their first dose of the vaccine, and their doctor advised them not to get the second dose. Could this individual go and get the other vaccine at this point in time?
So if it's an mRNA vaccine, I would not recommend that at all. And that's going to be a deeper discussion in terms of, well, if I took the Moderna, I had this severe reaction, can I take the Johnson & Johnson? And I don't know that we have any data on that, to be honest. I've not read any data on that. It is a different, like I said, platform. The Moderna and the Pfizer are an mRNA vaccine. The Johnson & Johnson is a viral vector vaccine, so it's different. Now, both of them are bringing in trying to expose the body to the spike protein, but we don't seem to see near as much immune response with the Johnson & Johnson as we have with the mRNA vaccine. So I would not recommend you switch, and try a different mRNA vaccine. And if you want to try Johnson & Johnson, that's a conversation they need to have with their doctor.
Okay. All right. We talked about getting a flu shot. What is the timing to do that? Say I'm up for my booster in October and I need to get a flu shot. Can we get them at the same time?
So technically you can. And the CDC says that you can technically get those vaccines at the same time. So I want to be clear, that's what the guidance is. Now, if you're asking my opinion, I'd say you get one and then you wait a while and get the other one. That's just my opinion in terms of immune response. Right now, as we've looked at the data from the Southern Hemisphere, they're just now coming out of their winter, and we always look there to see what the flu season is going to look like. The flu season wasn't that bad. It wasn't that bad in the Southern Hemisphere. So we're not sure how well it's going to translate for us. We're a lot more mobile and a lot more active than we were this time last year. You're not going to have, hopefully, schools shut down and that sort of thing. So we'll have the opportunity for flu to spread. And I would expect some flu, but I don't know that I'd expect this overwhelming flu epidemic, so to speak. That being said, you should still get your flu shot, but I would probably wait in between the booster dose before I get it, or I'd get the booster dose first. The fire in front of you is the Delta variant. We're seeing that spread. I've not heard of any. We picked up a flu. In our clinic, I guess about a month or two ago, we picked up a flu B, just kind of a random. We still test for it. We're looking for flu, in everybody, thinking it's going to show up at some point, but it's been real spotty just here and there. The fire in front of us is the Delta variant. So I would make sure that's my priority, is the booster vaccine.
Okay. And what about a pneumonia shot this fall?
Oh, if it's recommended that you get a pneumonia shot. Now, not everybody's recommended for that. It's only certain age groups and even under certain circumstances. But if it is recommended that you get your pneumonia shot, I would get that as well. And here's why, because when we talk about the Pneumovax, first of all, people may not realize this. If you get hit with COVID, and COVID's a respiratory virus, though it infects and affects other organs, influenza is a respiratory virus as well. That can knock down the immune system inside the lung lining. So it can basically denude or break down some of the mucus lining in the lungs and open you up for more infections. And so that pneumonia vaccine actually can protect you from some of the bacterial infections that would then secondarily give you, end you up back in the hospital. So it may be that, I made it, through COVID, my lungs, it wreaked havoc on my lungs, but I made it. And then 2 weeks later, you end up with a bacterial infection because you didn't have your pneumonia vaccine, which protects from bacterial infections in the pneumonia. There's certain groups that's recommended for, and that too is on the CDC website, but I do recommend the pneumonia vaccine if you're eligible.
Okay, great. I think you really covered everything else. It was a great presentation, and thank you so much for giving us an update on COVID. And I really appreciate how you break it down, and it's very easy to understand. And that just the information is fantastic to have. We really appreciate you doing that for us today.
Well, thank you.
We'll be staying tuned for another Lunch and Learn. Just check out our social media channels when we're going to have another one. Also, I'd like to invite everybody. We're having a tailgate at the Cooper Alumni Center this Saturday for the A-State versus Memphis game. We'll be here at the building from 3:30 to 5:30. Kickoff is at 6. We'll have food and drinks. We'll have bounce houses for the kids. We'll have some other activities for the kids. And we also have the Vicky McGee Band playing live for us. So come over and visit us on Saturday. We look forward to seeing everybody. I hope everybody has a great rest of the day. Thank you.